Hello everyone, this is IR Insights. Welcome once again to another special episode with a very, very, very special guest. He is the senior most interventional radiologist in the city, and he's the person where everybody knows him. He's none other than Dr. Ravi Kumar, who is a senior consultant at Apollo Hospitals, and he's the senior most interventional radiologist doing A to Z of interventional radiology. So today he's with us to share with us all about the techniques of embolization and the various embolic agents. So let's welcome Dr. Ravi Kumar. Hello, sir.
Hi, Deepa.
So how are you?
I'm doing good.
Looks like you had a busy day today. Busy day.
Okay. I was
Okay.
going to continue,
Okay.
but
Yeah.
in the short break, we said we will catch up with you.
Yeah, exactly. I mean, I've been actually looking forward to see you and discuss this with you because nowadays I feel like IR, as far as IR is concerned, there is so much of information everywhere. But then if we can consolidate the information and then if we can just give it across to the budding IRs, especially the things that they need to know, how fabulous will that be?
It's a fantastic initiative. This is a very important thing. யாராவது எடுக்க மாட்டாங்களான்னு யோசிச்சுட்டு இருப்பேன். அணை எடுத்துக்கலாம் சோம்பேறி.
Yeah.
But you took it as a very good initiative, and I think it will reach a lot of people.
I'm hoping so. I think the idea is to just help people, especially, I know you have fellows working for you, I have fellows as well. And sometimes, when they don't have a place, a go-to place,
Correct.
wherein they can actually look at, okay, this is what I need to. There isn't a library, like a digital library for them.
Exactly.
So I thought maybe we should create something like that. And I'm so grateful to you for agreeing.
In fact, I should be grateful and thankful to you.
Thank you.
Yeah.
Thank you so much. So, there is so much that, you are a genius and you've been in this field for a long time. And I myself learned so much from you. But then from your experience, we are just going back to the basics of IR. I think, none other than you would be the right person for this particular topic. So that, from your experience, from your vast experience, I thought I can ask you few questions on embolization.
Hopefully, for justice.
Yes, it's beyond expectation anyway. I'm sure you're going to do right justice for this particular topic. So coming to the embolization as such, I don't know where to start and where to end because it's such a huge topic. So the first question would be, what are the different types of embolic agents which are available? I know it's such a broad thing to discuss, but then what are the different types and how do you classify it?
In fact, when I started doing embolizations, so we were using patients' own blood clots, our blood or muscle tissue, or their fat tissue.
Right.
We used to take it and then we used to embolize.
Okay.
This was the stage I'm talking about in 1992.
Wow. Okay.
But slowly now the embolization particles have come up so beautifully that in fact in Bombay, I had my boss, Dr. Ravi Kumar.
Mm-hmm.
He used to cut gel foam into various particle size, 50 to 100, 100 to 150. Abdin potu, he will make it, he will autoclave it and bring it into small sachet.
Wow.
So
Okay.
I never realized, இதெல்லாம் available, இப்படிதான் இருக்கும் போல இருக்கு அப்படின்னு I was thinking. It was amazing. We used to just open it and we used to take the particle, mix it in saline and water and then start injecting it.
Okay.
And when I came back to Chennai and I realized, I have to start all together because everything was given in a platform plus.
Correct.
Now it became, then we started preparing on table how to do that. The gel foam was the most commonest thing that we used at that point of time.
Yeah.
But as you know very well, it's a temporary embolizing agent. It's not a permanent one.
Correct.
And by the time Cook had already come with the Cook in Boston, they already came up with the PVA particles.
Correct. Okay.
So, and then when we were, if they come for a pre-op embolization, we used to do gel foam. If it is not permanent then we start using PVA.
Yeah.
The only problem was the cost factor.
Correct.
Because the cost factor became a little bit of an issue. So that's how we used to do. But, recently we had a IR training program in Coimbatore. Other than that, we were talking about embolization particles. I realized that many people are scared. In fact, they had an inhibition of using embolization particles. So how I addressed to them was, I thought, which may be useful in this forum also. But everybody is doing guided biopsies, ultrasound guided biopsies, CT guided biopsies. So I said, in order to get over it, I said, now from tomorrow onwards, let us start doing ultrasound guided liver biopsies using coaxial needle. When they're coming out, tract embolization, do the tract embolization, come off.
Correct.
So they said, oh, we can also do it out. I said, that's how we start off. So what I said to them was, cut the gel foam into small particles, into small pledgets.
Okay.
And you have a technique called Tazare technique, which you know, but of course you mix it with saline, make it into a nice pasty-like thing. Once your biopsy is over, we inject and come off. Now, all the procedures, all the fellows, whoever does biopsies in here with me, they've been trained to do that.
Very nice.
So this will take away the inhibition of using gel foam as such.
Correct.
So then, if they start doing this, then they can go into various other embolization particles like PVA. Then they start using lipidol, gel foam, glue. They can use coils. They can use amp-large vascular plug. And it goes on and on.
Okay.
But this is first to start away on a daily basis. They should get the hang of making the gel foam into a nice pasty kind.
Correct.
The preparation of the gel foam itself is an art. So as we go, maybe we will discuss more about it.
Yeah. So, from what you have said, gel foam preparation, I know only one method of preparation. I've been using it all my life.
Sure.
I would be keen to understand what is a technique that you would use.
Yeah.
Because the other day I was talking to another senior interventional radiologist, and he said normally he would just soak the gel foam in the contrast even before, just make it just cut it across and then put it in the contrast, let it soak so that it's already soaking, and later on you just put it in the, in the syringe, and then you use a 3-way tap and then you mix it. That was a technique, but it was a small tip that he shared. I don't soak it in the contrast. We actually put it and then you do it, mix it. And sometimes the whole syringe pops and then it's all over the place. And I've seen all of that. But
in fact, that is a beautiful thing. That is, especially we soak it in contrast when we're using it in the cath lab. So it also helps us to see how the little bit of contrast goes.
Yeah.
But in your ultrasound, we don't mix contrast. We put it in saline and then just cut it off. It will be like small pellets. We will show you the demos of.
Is there any powder as well? There are people talking about.
So this is for when you're using large. If you're using portal vein embolization, you need not have small particles. We just make these big pellets and then embolize it off. In case if you're using, that is the time when we scrape the ab gel. So then. That scraping, I use normally 11 number blade, and we have the gel foam pad, and then we scrape it slowly.
Yeah.
Depending on the particle, when you're scraping itself, I know what is roughly the particle size. Of course, we cannot be as accurate as it'll be 100 microns, 200 microns. Yeah. But if looking at the vascularity, we'll know this is what we have to complete. And then the more thing is, once a particle is coming into your separate ball, now you need to add contrast and you need to add saline. And in the mixture, usually what happens is, I'll say, either 1.5 contrast and 1 ml of saline protein. Now, at the end of the whole thing, if you take the 5cc or 10cc syringe or the whole thing, you should see that uniform distribution from top to bottom.
Oh, I see.
Only when you're injecting there, sometimes it'll get settled in the bottom of the syringe or it'll be on the top of the syringe. That means if it is in the bottom, then you need a little bit of saline. Or if it's the top, then you put some contrast. So then you see how it goes. And then when you take it up and see if it's a uniform distribution, then when you're injecting this gel foam, always use pulsatile technique. Don't just keep pushing the syringe totally off and then say this is what it happens. So use the small, you need to have this pulsatile technique.
Yeah. Okay.
At our level, maybe the more we do it, it comes spontaneously. But for the new guys, there are separate syringes which come for them.
Yeah.
Like Merit has got some syringe. So then they get this pulsatile technique, because this will be useful when they're using DC bead embolization, all these things. So when you're using DC bead embolization, we have to use only pulsatile technique. Then only it pushes the whole thing into the bed of the tumor. And invariably, we will say for every 1 cc of, and I always use 1 cc syringe to inject embolization part.
Right, okay.
Follow it up 2 cc's of saline.
Right.
So 1 cc gel foam, 1 cc saline, or 1 cc PVA particle, 2 cc's of saline. So in the combination, you have to inform the sister. And another common mistake that I have seen what is happening at day-to-day practices, routine contrast saline should be kept separately from the gel foam. Get the whole thing separate. Remove the number. When you're doing the angiogram, we have already saline and contrast mixed.
Correct.
So generally we try to take the sisters will immediately take it from
the...
all these particles will go there.
Correct.
So, I always say to all the people saying that, boss, don't do that.
Okay.
So, have it separately so it doesn't get confused. So, either take it off separately, use the normal thing, and then come back.
Okay.
So, either key important take homes are it should be a uniform distribution, be it PVA particle or gel form, and pulsatile injection, and always it should not be. You should follow it up with saline. Every 1 ml followed by 2 ml of saline.
Correct.
So embolization becomes much better.
Yes. A couple of things about gel foam is where do we use it and where do we not use it?
Yeah.
For example, I'll just go from top to bottom. We'll just start, let's say, from the bronchial artery.
Yeah.
This is just for the sake of people who are watching it, to just get to understand. Bronchial artery embolization, would you use gel foam or not?
Yes, we can use gel foam.
Yeah.
But again, as you know, it's permanent and temporary.
Yeah.
So now I shifted totally to when we're doing it in KM Hospital in Mumbai, then we were doing it in gel form. It is available.
Right. Yeah.
But now we started using particles because
you use the PVA particles for the most.
But rarely I use coils.
Right. Okay.
Unless there is a arteriopulmonary fistulous communication, which we see it.
Okay.
So, if it is there, then we use a coil in there. Right. Because our patients come from different part of the place. Yeah. They don't come back to us.
Portal vein embolization.
Portal vein embolization definitely should be a permanent embolization.
Yeah.
They'll use PVA.
You all prefer PVA to the... because that's what I wanted to say. Like, we used gel foam in one patient only and then the result was not good.
Okay.
There was no adequate hypertrophy. And they said, although the literature says, maybe gel foam can be used, but that...
there are two different schools, but I always use PVA because we need to create ischemia to release the growth factors.
Okay.
Only when the growth factor comes, the remaining volume of the liver becomes high. So, we have to create ischemia.
We have to grow this.
But the ischemia is temporary. Then the growth factor stops. And we are looking at 4 weeks to 6 weeks.
Very nice point. Very nice point. Recently we had a jejunal bleed.
Okay.
Would you use in such a scenario?
Yes. Jejunal bleed, again, always look into the vascularity and then use if it is, once you see it's, say something like a vasculitis picture, he was usually how the GA bleed they've done a coronary artery stenting and then there's a bleed there. Otherwise, you can use gel foam and back.
Can use gel foam.
Or you can use your...
So there's no harm in that,
No harm in it.
How about uterine fibroid embolization?
Uterine fibroid, again, we're looking at a permanent because we want to shrink it. I always use PVA particle. I think standard is 350 to 500 is a particle size.
PPH.
Yeah. PPH again, yes. Now, you can use gel foam. But again, because why gel foam? If they have not completed the family, the family has to be there. Then you can put coils and they get back and save the whole thing at that point of time. But India, what we do in PPH is we use the balloon inflation method for both before they...
Yeah. But let's say we didn't do that and then the patient is bleeding and they didn't ask for a balloon occlusion.
Again, that is a very difficult call. Because here I've used always PVA because one patient we have had bleeding stop for 24 hours and it started profusely bleeding.
Oh, okay.
So that was a problem. Maybe I don't know whether it is following that I started doing all embolization using PVA particles.
Yeah. Okay.
So again, I don't know what the literature says, but maybe I should get back to the literature and see what really is happening as of now.
Right. Okay. So I think the takeaway for people here is if you use gel foam, as Dr. Ravi says, it's a temporary embolic agent, and you need to understand how to mix gel foam. As it's coming on the screen, you will understand the gel foam is mixed in a particular way, and when you need to add contrast, when you need to add saline, when it sediments, and follow it up with saline. All these tips, I think we need to take it. And when do we not use gel foam? What are the conditions where we don't use gel foam? Again, portal vein embolization, PPH. Bronchial artery embolization, we probably don't use gel foam, but there are a lot of other places wherein we can use gel foam. So we'll just move on to the next embolic agent. The next embolic agent is the particles. I wanted to ask you about.
Now we go from the temporary to the permanent. Now what we're going to talk is all permanent embolization. So the next thing which developed was polyvinyl alcohol particles. So they made it so easy to do that. And again, it comes in different sizes, 50, 100. They sometimes some people give it as a range. Many companies come with and up to 1,000 micron size particles are there. Usually beyond 1,000 we rarely use it because your microcatheter. Certain tips that I would like to give here is like you need to plan the procedure well ahead of time. When you say plan, because invariably we'll be using microcatheters. And a microcatheter, what is the diameter? Inner diameter of the microcatheter, whether it's 1.6, 2.1, because each microcatheter will take up to 700 to 1,000. Once after beyond 500 micron, the catheter gets blocked. And then sometimes you'll have a real tough job in clearing that. So first I would say to the IR fellows or even the consultants who are starting to do embolization, choose your hardware. Based on the hardware, choose your embolization material. If you already decided embolization material, choose the hardware based on that. So this is one thing. And generally, again, the preparation part, initially what I used to do, I thought the number of particles, if it is distributed more, the embolization will be better. But what happens is, what I mean by that is, when you take a syringe after mixing the correct proportion and there's an equal distribution from top to bottom, I always keep it to less than 50% of particle to be in that particular syringe, not the jam-packed particle which is there. Because what I've seen is, over a period of time, like you start injecting, within 2-3 injections, you get a good embolization there. And you might tend to stop it. But that is very temporary, because still the flow is going to continue. So when I keep a mixture where I have, for every syringe I've got less particle, less than 50% of the particle, I inject more particles into the bed and make sure the embolization is near complete embolization. So this, especially uterine fibroids, prostatic artery, all these things will really help you out. So I make my distribution of particle in that way. Again, I follow the same: 1 cc of this, 2 cc of saline, 1 cc of particle, 2 cc of saline. So make sure your particle, everything goes out very clearly. Okay. And when you're injecting, again, this also has to be pulsatile. And when you're injecting into the thing, you will know whether your catheter is getting blocked or not. If the catheter is getting blocked, that means you need to dilute more your particles inside. So these are small tips, but I think over a period of time you'll start using it. Comes from the spinal level, so you'll start using it.
So 1,000 micron PVA particles. What is the microcatheter size that we should use for
that? The progress by 2.1 inner diameter size.
Anything about 2.1. It should not be anything less than 2.1 for that. So the recent catheters have been...
I think 500 to 700, I think your Maestro, which has got a size of 1.6 can take. Even your Progress also has come with 1.6. So that's all. So if you're using a coil, again, if you're going to use coil and particle, so your 1.6 microcatheter will not allow to 1.8 coil. So that time you'll get stuck. It will allow up to the midpoint, but not allow distally. So I think that's something. Once you've decided, see the angiogram. Always see the angiogram first. Decide whether is there a possibility of me going to use a coil. Then choose your hardware based on that, and then you can finish it.
What is the size of the particles that you would use for bronchial artery embolization?
See, for standardly it has become 300 to 500.
300 to 500.
Most of it. For most of it.
Even for fibroids?
Fibroid, I will start using a smaller particle size so that the bed takes care of the initial phase, followed up with 300 to 500.
Oh, I see. So you mean you use the 500 to 700 first?
No, I'll use smaller particle.
You use a smaller than that?
Particle. Oh. So I will use less than the 250 to 350 is there.
Oh, okay.
So I will use that particle to create a bed which is nice, and then I use a 350 to 500 particle to complete the embolization.
Have you noticed any increase in the ischemic pain with the smaller size particles?
Yes. When there is definitely ischemic pain, and for my patients with uterine fibroid, I invariably give epidural. So, and I keep the epidural catheter there for at least 24 hours. But I mean, of course, now abroad, I know you have done a lot of things abroad, but where they do the outpatient procedure, so they mix off the lidocaine inside the contrast, they give the thing, and then they start doing. But here, invariably, I don't know, our patient tolerance, pain tolerance is bad, so I keep the epidural there for at least 24 hours.
You haven't noticed any risk of myometrial ischemia or anything with the small particles?
No,
they've been fine.
No, because again, depending on the vascularity, and invariably all my patients will have a CT angio of the particular thing, and we have a transvaginal Doppler. So depending on the vascularity, I decide whether I need. So this is not becoming a dictum that I always have to use small and big smaller. So I decide looking at the size of the vessel, the vascularity.
And the economy also matters, I suppose, because the smaller the size, more the number of vials we may have to use.
Correct.
And
that is also there. Up to then standard 350 to 500 is my size.
Do you ever mix PVA and gel foam because of the the economic status that people may not afford?
Yes.
First give PVA and pack it up with
PVA, and then you can pack it up with gel.
Pack it up with gel.
I mean, for some cases we had to do it because again, economical thing is one thing. We have to see in our patients. So I've done that.
Okay. And in terms of the PVA particles, what is your mixing protocol? How much, how much of contrast you take, and what is the type of contrast you take?
It be the same. I always take neat contrast. See, for an I don't mix the angiographic contrast. What we already mix 1:2 or 1:2 water. I always take neat contrast.
Yeah.
And I have the saline there.
Yeah.
Again, take 1.5 ml of contrast, 1 ml of saline. Again, see how your mixture is. If the ratio is good, then I keep the same ratio and dilute the entire. And I don't empty the entire PVA at one go.
Oh, that's what I want to ask.
Whatever the bottle comes.
Yeah.
So I take less than 30% or 50% first. Put it slowly because I need a good amount. As I said, I need a good distribution of material.
Yeah.
So if I pour off everything, what happens is that I need to use a large amount of contour. My bowl has to be big.
Yeah.
So in order to make sure that I don't waste also, at the same time, I take only less than 30% first. Then I'll again remix it once again. Then I'll again remix it once again. That's how I go.
So when you take less than 30% of the PVA particles, how much contrast and how much saline you mix?
The same ratio, 1.5:1 ml.
Yeah. Okay.
My thing, finally, it has to be uniform distribution. Based on how the first thing comes, then I start knowing whether I need to add saline or need to add contrast. So in that way, it will help.
Okay. And what is the deciding factor between PVA and embospheres? When do you choose embospheres?
Okay.
When do you choose?
See, now, the main difference between the PVA and embosphere is what they say. The embosphere is like uniform sized particle, more uniform sized particle. When they say it is 300 microns, so that means more than 80% of the particle size there is 300 microns. But in PVA, you cannot make that kind of a very strict thing. So that is why. So this kind of uniform embolization in prostate artery and uterine fibroid embolization, embosphere results have been shown to be much better.
Okay.
But again, embosphere is expensive, PVA particle is expensive. When the economy, when the cost factor comes in, then we have to decide what is best.
Have you noticed in your experience that embospheres, they do not, cause the clumping or, blockage of the catheters compared to PVA because of the different sizes?
That's a very good point, in fact, because it is less clumpy when compared to thing. But since they follow the same preparatory process for PVA and the thing like saying that it doesn't, the number of particle size, I keep it maintaining the same. I'm not really found it, but I've read the literature. Yes, it causes less of clumpiness and it is a valid point.
Maybe what you say probably makes sense because I think people always mix a whole bottle.
Yes.
So when you do that, it probably clumps faster with PVA compared to
because the particle will start increasing size. See, just allow that size to increase. So another making it a little by little. It doesn't happen in gel form. Gel form doesn't swell up like that, but these guys really swell up quite a bit when you see carefully.
Okay. Oh, perfect. So now we'll move on to the particles we are done with. So we'll just move on to the liquid embolic agents. So what is your go-to liquid embolic agent?
My thing is glue.
Glue. Okay.
And initially I was a little bit scared of using glue. And in one of the conferences where I showed GI embolization particle, there were a lot of coils, there were a lot of gel foam PVA. The panelist asked, "Doctor, you have not used glue much. Why is that?" So I openly said to him, "See, my exposure to glue is very little. This was around 10, 20 years back."
Right.
But then now, in fact, if you see, the art of glue is fantastic, unbelievable. But it has got a long learning curve. So first, for the people who are starting, make sure you stick on with your bosses. They have to know how you go about preparing and injecting. Because again, look into the vascularity. So you decide on the vascularity, because here the percentage of glue is very important. So a percentage goes anywhere between, I use 16 to 33%. Very rarely I come down below 16. So, but when I say what this percentage means for the people to understand better is, glue is a non-opaque agent. So like how PVA gel formed are non-opaque, so we add contrast. In order to make it opaque, we mix it with lipid oil, which is poppy seed oil. So in the combination, suppose if I take 1 ml of glue and I mix it with 1 ml of lipid oil, it becomes 50%. And 50% glue, we don't use it in our embolization because the moment you inject, it's going to form it's going to polymerize and upload it. So it will anyway invariably be less than 50%. So if I mix 1 ml of glue and 2 ml of lipid oil, 1 by 3 into 100, that becomes 33%. So in that way, I can vary. Now 1 ml of glue, 4 ml of lipid oil. So 1 by 5 into 100, that becomes 20%. So in that way, you judge what is the ratio of mixture that you have to make. Preparation of glue, again, is an art.
Okay.
The sisters invariably don't give new balls. Whatever is there available, saline, they will just clean it and give it to you. Make sure it is totally separate because even a small amount of saline or anything is there, it polymerizes. Without your knowledge, it will be polymerized there. At the time of injection, you get screwed up so badly. So I will invariably say, make sure it is a new tray altogether. Number 1. Number 2, dextrose has to be there. Take away all your saline particles, dextrose has to be there. And once the catheter is reached, because there's going to be a time gap between your catheter is already there where you have to embolize and you're going to wait because you're going to prepare the glue. So you turn off entirely this side and start preparing the glue. But mind you, blood keeps coming. The back of the catheter, there's a 0.6 ml of dead space in your microcatheter waiting there. So make sure somebody keeps injecting dextrose into the microcatheter. Keep on continuously. I invariably say not a small drop blood of thing has to be in the hub of the microcatheter. So that somebody has to take care. So now you start preparing it and you already prepared. So once you have prepared the glue, then again, either it can be 3 ml or 1 ml depending again on how much you want to inject. Because here I'm not looking at a nice pressure for injection. So when I need a good pressure for injection, I use 1 ml size for PVA particle, for a tumor to embolize, all these 1 ml helps. But here minimum is 3 ml I take because now this is going to be a controlled injection of glue. And now I attach of the glue after making sure dextrose is given. Again, one more important point is invariably before embolization, we always say, let us take a check shot to make sure that my catheter is there. We ask sister for the contrast, inject contrast. Again, followed up with 10 ml of dextrose. Don't allow the contrast to be there. So once you're sure, immediately connect off the glue syringe, whatever you have prepared. And now, this is not pulsatile injection. Never go pulsatile with the glue. The first injection of glue, what you goes there, it will just fly off. Don't get scared. As long as you're there inside. So keep injecting slowly. Don't make it reflux fast. Try to form a glue cast in the area where you have to be. And then you keep injecting slowly. Suppose if you feel, I need a more better penetration. Immediately remove the syringe, use dextrose 3 ml syringe and you see it. It will go again slowly. Now again, there is a difference in the density of dextrose and your glue. When you're injecting dextrose, inject very slowly. You will see that it will again fly off. The same thing, you use it in PVA particle thing, you see the moment you start using saline, total difference in density. Immediately you'll fly off. So these small things are like, I said, a glue injection is an art. You have to be very careful in injecting. Then once you've created the whole thing, again, if your glue preparation is such a way that it forms a nice pasty-like thing, like onyx. When you use onyx, you will see it be like that kind of an injection. If you can get it in glue, you're like the real boss in it. This is what you need.
So have you seen people talk about the catheters getting stuck and little pieces left in the brain also when they try to do some glue embolization? So have you ever had that experience of...
Yes, at KU Mumbai, we had, and my boss Ravi Kumar is king of neuro intervention. He just said, "Kuch nahi hota hai. Nothing happens. Just leave it." But yes, it happens. So that's why Nowadays, the neuro, they have these detachable catheters come out. So when you pull it, the tip alone of the thing becomes detachable.
Like a biodegradable.
The reporting catheter comes out.
Right.
But we don't have the luxury in body intervention because we don't have detachable. But of course, we can use a neuro.
Yeah.
But again, expense. The expense is so.
So what do you do if it gets stuck?
Again, what happens? That's what. So when you know that's why I'm saying the glue has got a longer learning curve. So you can use a little bit of force. It is not that, because that is why I'm saying that if you prepare less than 20, you've got a polymerization time at least for 45 seconds. Don't keep on waiting till, once you're happy with the thing, just come out. Or once you're happy with embolization, whatever has happened, take dextrose, clear off the tip of the catheter. Okay, that is the one which catches the hole. Clear that catheter off from the glue. Remove the catheter a little bit back and wait. Nothing happens. So by the time it does get polymerized.
So for the sake of discussion, for the sake of everybody, it's in terms of the 1:3 to 1:5 mixture. If you want the glue to go distally, let's say we are doing a porcine embolization.
Exactly.
You make it more dilute.
Correct.
And you can even go up to 1:7 as well, depending on the flow. And look at the flow dynamics, look at the circulation.
Because as you rightly said, we're looking at ischemia. So
exactly.
the more the branches go, it causes ischemia.
It causes ischemia. So based on that, you get your glue dilation. There is no standard format like it should be 16% or 33%. Just look at the thing, how distally you want the glue to go, and based on that, you do that.
Exactly.
For aneurysms, when you have do you ever embolize a pseudoaneurysm? Because a lot of people, I've seen people embolizing a pseudoaneurysm with a glue. So what's your...
See, now, if it's a pseudoaneurysm, I'm not able to enter into the pseudoaneurysm. Then I would prefer trapping it by using coils. If I'm able to get into the pseudoaneurysm, then I inject glue. Because my microcatheter has...
Never coils, but you can always inject.
Yes. Again, the cost factor. And because one thing what happens in the now since I've become a little bit more easier with glue, so I started using glue. But as you said, you can fix up the coil and then you can come out with the coil itself. Perfect.
Because sometimes the understanding is that, the coil, the weight of the coil can actually rupture the pseudoaneurysm. Unlike a true aneurysm wherein you pack it out nicely, but then never coil for a pseudoaneurysm. But glue we can always inject for a pseudoaneurysm. Okay, so it was very interesting discussion on the liquid embolic agents and also the particles. And I'm sure, most of the people's doubts are cleared with your explanation. We'll move on to the most commonly used embolic agent now. So the next embolic agent, coils. Now people have a lot of doubts about the first question that my fellows ask me is, how do you decide on the size of the coil? So how do we decide on the size of the coil?
It's a very difficult to answer that question because we see the coil size what is available. It starts at 2 millimeters. I think Boston has introduced a 1 millimeter coil which is there. Again, when we started, it was 2, 3, 4, 6, and then, of course, 8, 10, 11. So now, whatever we had was a minimum was 2 millimeter. And my favorite coil at that time, what we started was the Cook coils, what we had. Cook had this Hilal micro coils. But now what happens is the micro nester has come. So... Now, whatever I was using as a Hilal micro coil, I started using micro nester. The size again, if you see the angiogram, the more periphery you go, the least size what you got is 2 millimeter. Either you don't have a choice at all because you're in the vesa recta, and that though it is a 1 millimeter, now you got a size that you can use 1 millimeter. But that time we had only 2 millimeter. But we invariably tried to form one coil distally, and the first coil turn varavarikku you will have difficulty. Then automatically the next coil comes off. Because the 1 millimeter coil invariably stays straight. So now you are the vesa recta branch, and then there's a transverse branch which is a breeder. So now you can use that and then put a linear coil and back off. So that way we can do. But not much a 1 millimeter coil. Still, even today, I have not used. 2 millimeters is my standard thing. But your micro nest, that's why they call it as micro nester.
Okay.
Even if it goes to the smaller size, it can form a small micro nest into the particular vessel. So in that which a Hilal microcoil will not. In fact, we have ruptured vessels when you try to make a coil with Hilal. Because Hilal has got these side branches and it's more stiffer when you compare to the microcrystal. So now we have got 2 millimeter, 3, 6. So in deploying a coil, what I would say is try to form the first coil, which I call a jalebi technique. So you, at the end of the whole thing, you must have a nice jalebi coming out and forming. That is the art of doing a coil embolization.
Right.
Sometimes you go with the intent, but then it forms straight. And then you form a coil, then you because that is not a good, but sometimes it happens to be even today.
Yeah.
Because, and there are a few tricks or tips, what I would say is have the mother catheter as distal as possible. Generally say if it is an SMA branch, we generally keep it at the SMA and then we take the microcatheter to the 4th jejunal branch and then start putting coils. We've had problems. So what I do is I take the mother catheter right up to the 4th jejunal branch or as distal as possible, and then because I need a good support.
Yeah.
Because when you're doing it from here, when you start pushing the coil, you forget to see the aorta, SMA and all that. We have seen that the whole catheter has come out and the coil doesn't go. That is the time when we have these straight things and all that. So just to avoid all that.
Correct.
In that way, I think you need to choose the coils.
Yeah.
Again, in a coil, what we have is both thrombogenic and occlusive. Whereas in brain aneurysm, it's more occlusive coils. So they don't want a thrombus. So that's why they keep packing it. But ours are both thrombogenic and occlusive. So in that way, our coils are a little bit more thrombogenic. Again, when you're choosing GI bleed embolizations, never try to do more than 3 vasa recta. More than 3 vasa recta you embolize, that means there's a bound to be ischemia, infarct, where you have to embolize. So try to minimize. Try to minimize your amount of vasa recta embolizing. In a sphenic artery, hepatic artery, and all, I think that depends on
the size of the artery.
Artery.
What's the difference between the artery and the vein?
Vein, see, artery does not have the thing to expand. But vein, it can have more space, and it also, even you can stuff in even 8 millimeter or 10 millimeter coil in a 6 millimeter diameter portal vein because the wall doesn't have all the 3 layers. The wall is a little bit more, you can expand. And in veins again, the carrying away of my my coil is very less. So I can use even a smaller size. Suppose if it's an 8 millimeter vessel and I want to nicely pack it, I use a 6 millimeter diameter. But in the other way around, if I'm using a smaller size coil for a bigger size vessel, it can get carried. Suppose I'm using sphenic artery.
But is there a risk of reflux in a vein if you use a smaller sized coil in a vein?
But what happens is when you nicely pack it up, that's why your jalebi technique will be the best. If you make it a nice coiling into the jam packed. Because sometimes what I've seen is when you choose exact size to size, say it's a 10 millimeter, let us use a 10 millimeter coil, it forms a coil, but you'll see a lot of gaps inside the coil. And then when you inject, it is not a perfect embolization. Then invariably you will start using a smaller size to fill in those. Just see the brain part. Brain part, we do that. See, initially what they do is they form the outer scaffolding part, and then they keep on filling the inside part. The same thing will happen here also. So instead of doing that, I need a peripheral embolization of the portal vein or whatever. Then I use a smaller size, nicely pack it, come back, use a bigger size. Of course, again, you will be tending to use more coils. So again, the cost factor is a problem. That's why we started using glue for that also.
Correct. Yeah, absolutely. So in vein, we can oversize by 10%. 10%. By 10% oversizing is fine. And because you spoke about the scaffolding, just for the sake of people who are listening to this, for the scaffolding, people use you use a Nestor coil in the middle, use a platinum coils, and then surrounded by steel coil. Is that what people normally do?
In most of the GI kind of embolizations, I don't use the combination of things. I go off.
Just the standard.
That's a standard thing. But only if there's a gap in between, I create a coil, then I put another smaller coil to do that.
Okay.
Again, one thing when coil, one is the size, another is the length. you have to decide it very carefully before going in for embolization.
Yeah.
So what happens is now only detachable coils account for the peripheral vascular interventions. Till the time before the detachable coils, we had no choice.
Yeah.
Either you put the coil, if you are not happy, you remove the catheter coil, recatheterize everything, and coil it. So it's better to choose a right size coil, right size length.
Yeah.
So start off with a smaller length and a proper diameter coil first to start off. And then you can go, because now there are 14-3 coils. And when we say 14-3, it's a 14 centimeter length and 3 millimeter diameter. Like that, you got 7-3, you got 5-3.
Yeah.
So try to choose. The first coil, when somebody is deploying, always say, try to use a smaller one, get the hang of using a coil. And then you start building it upon it. Once you're seniors, and then you know what the size you want, how to make it.
Yeah. When do you use the flush technique, and when do you use the back end of the wire and then the front end of the wire?
Now, if I want a nice jalebi right from the first part, I will start pushing the coil right from the point of entry.
Yeah.
Suppose you got some good space to play around, then I inject the coil.
Yeah.
Then the first bit of comes out, then we make the coil.
Right. Okay. Yeah. Right. So there's so much to talk about coils, but then just for the sake of the time, we'll just move on to the next one. Coming to the last part of the embolic agent, Amplatzer plugs. So please enlighten us on the different Amplatzer plugs that we have.
See, now here what we commonly use is the two companies that come, Abbott and Sera. And Abbott is more of it is got only made of wires, but Sera has got a cloth inside.
Yeah.
So the important difference is you release a CRAP and you do it within 5 minutes. It is a very good cutoff because you got a cloth in it and thrombotic process more faster and quicker. But in Amplatzer vascular, you need to wait at 15-20 minutes to look into how good you embolize. That is one thing. And CRAP, again, you can use it in smaller size sheets, smaller size catheters when compared to Amplatzer vascular plug. The common Amplatzer vascular plug, what we use in our system is either it is AVP2 or AVP4. So these are the two things that we use. So we usually take 25% size more than the size of the vessel. Usually, where do you use it?
Yes, exactly.
We use it in splenic artery. We use it in BRTOs and or any venous size where if you're doing all the ectopic varix and all these things where you have to embolize, we use the Amplatzer vascular plug and then start using it.
Fistulas?
And yes, fistulas, Amplatzer vascular plug is fantastic. Yes, that's a very important
portal vein?
thing. Yes, portal vein, Amplatzer vascular plug, I have not used much, but
people have used, I think, in the main portal vein, and then you embolize, follow it up with glue for the rest of
correct. Like, correct. So you use it there and then you...
Main, you use the Amplatzer, and then distally, you're more safer using glue that way.
No, what? Because, I would have the flow maintained for my penetration of the glue till the end of the whole thing. And coming back, maybe if I need, if I have a good embolization, then I don't use vascular plugs. Because once you put out the vascular plug here,
there's no flow.
Then my flow is very much...
it's a very good point.
So then what I do is invariably block everything. If my ischemic component, if I feel that it is not great, I've not gone into the second order, third order. Portal.
You feel it causes proximal embolization because no flow.
Then I will plug it
that's a good point.
So, but in all BRTOs, we have started using...
So how do you use plug in a BRTO? So when you're doing PARTO, so in that first you deploy, so you take a sheath. What size sheath do you take into the...
Now either I can use a bigger size. That's what. So now when you're using an Amplatzer vascular plug, I need to have at least a 10 front sheath to be inserted into the 10 or 12 front sheath. I need to get into the arterial vein. But whereas when I use Sera, what I use in 10, I can have a second microcatheter going on top of it. Otherwise, I'll have to have two punctures.
Correct.
Two punctures, both getting one smaller sheet there, getting my microcatheter there, and then come back out. But your 10 French or a 12 French sheet will allow one microcatheter to go distally. And then you can still deploy your Amplatzer vascular plug proximally. And then you can finish embolization.
And you use gel foam there? Once you deploy the plug, from the microcatheter?
Now I started using again glue.
Glue.
Okay. So because once I'm sure that I'm in a good gastric varix, then now I modified my technique a little bit so that I do percutaneously access the gastric varix through the splenic vein. And I know where my gastric fundic varix is. Okay. Because sometimes what happens is even after doing parto, I mean, inject, suppose my microcatheter will not be able to reach to the end of the gastric varix. Water, because of it, so much of coil, so much of turns. So if I don't be there, then my whole embolization part may be a little bit. So I percutaneously access it because I can see.
It's like a Barto plus BRTO.
BRTO. So I percutaneously access it. When I inject, I know that the whole contrast is there. I inject off part in my glue and then back.
And then you have the glue anyway, and then you embolize the tract also.
So now I started doing more of these percutaneous access, put off a coil or a parto here, and then finish the process.
Okay, now that, I mean, it's deviating from the topic, now that we're talking about the splenic vein access to get into the gastric varix. No issues at all getting from the splenic vein into the gastric varix, and no risks of bleeding or anything, because all these patients, they are liver patients, they may have low platelets, getting into the splenic vein.
That's why the tract embolization, I always use glue. Because glue is more better, because it's whatever, it doesn't depend on your prothrombin or whatever. So the things are. So, touch wood, till date, we have not had any problems with the percutaneous access. Because I'm with these guys' spleens are big. I mean, not trying to puncture a spleen size.
And that itself provides a tamponade.
Provides a tamponade effect.
Yeah. And in terms of the plug for the BRTO, what is the size of the plug that you would normally use?
Normally what we have used is 14 and 16 millimeter.
Okay.
And invariably, in all BRTOs, if you see before the adrenal vein drains into the renal vein, you'll see a small waist. Yeah. So make sure that your sheath goes above those, so that the first plug is above the thing. The
second dumbbell is below, and the first dumbbell is above.
So in that way, you're sure that because sometimes you're scared that with the plug
it can
fly
come back, and
so this way you make sure that
it snugly fits and sits there along the thing. Yeah. Okay, very interesting. So I think I pretty much asked most of the embolic agents. I don't know if I'm not aware of something. Please tell me something that I missed other than...
I think we covered most of it. And as an initial thing, I think if this people can understand.
Yeah.
They most stay with the proctor or the boss. They will learn much more better.
Yeah. No, that's wonderful, Dr. Ravi. I think it's been an enlightening. I myself, again, as usual, I learned so much talking to you. So I'm sure most of you, understand all about embolization, right from basics to advanced. We'll cover in depth in future, exclusively on BRTO, exclusively on portal vein embolization. But for now, just to get a general perspective, I think it's, fairly, good enlightenment on those topics at least. So thank you so much once again for your time. Thank you. And thank you all.
Thank you.